Dr. Hans Dillinger, an invited lecturer, and he will talk about imaging as a possible catalyst for tissue-engineered heart valves development and translation. Thank you.
Thank you very much for the kind introduction and also for the possibility to speak at this very nice event. Can you hear me okay? Very good. Sorry for bringing up the bottle. My voice is a little bit suffering from the AC though. I have nothing to disclose and no financial interests, but another disclosure, I'm a PhD, I'm not an MD, so if anything comes up, please. The session is called A New Era for Heart Valve Tissue Engineering. And today we really stand at the threshold of a new era. We're not repairing heart valves, but we are actually replacing them. The promise of heart valve tissue engineering, once a vision for the future, is now a reality. But to move from promise to practice, we really need more than good fundamental science. We need enabling technologies. And if we look what has happened during the past 50 years, there was a huge transition from, I put an artificial heart here that on the left-hand side that actually incorporates 130 kilograms air compressor, and on the right-hand side, very novel approaches to heart valves. So we've seen this picture today already, but I still want to show it because it very nicely illustrates the historical landmarks in heart valve replacement. So we started with mechanical valves, and nowadays we have biological valve replacements. But what about the numbers? The numbers are growing. So this is an older paper that states that until 2050, the overall heart valve transplants will be growing 3 times more. And another study that is from 2018 predicted that the TAVI interventions would multiply by 1.5. And it's interesting because 2019, the FDA approved TAVR for also low-risk patients, and then TAVI exceeds all surgical aortic valve replacements. So it's quite an important topic for everybody being here, I believe. So this is the outline of my talk. I want to start with the current hurdles. We go to insights from imaging, what imaging could provide us with, and lastly, a combination of the disciplines that we need. So let's have a look first at the current hurdles. So we are at the crossroads. Does the patient need a mechanical valve or a bioprosthetic valve? And I'm an engineer. I was very puzzled when I saw the decision tree. And it's really about heart limits, about the age, and very strong decisions about the outcome, patient age, and the risk for reoperation. So that for bioprosthetic valves, the risk for reoperation is quite high if you're younger. Speaking of younger patients, there is a problem in pediatrics. So it's very clear if the patient is older than 20 years, it's going to be a mechanical heart valve. If the patient is older than 65 years, it's going to be a bioprosthetic valve. So the long-term survival is kind of identical, but for the mechanical valves, as we've seen today also, there are thrombotic complications, and they require lifetime anticoagulation. For the bioprosthetic valves, there is a risk of rupture and excessive deterioration after 15 years. And now what's with the red bar? That's the pediatric patients. So I put here one plot that shows the body surface area against the diameter of the aortic sinus. And you see that the child is growing from 2 years to 20 years. The body surface area increases, and so does the aortic sinus diameter. So it's clear that a mechanical heart valve is kind of not suitable for a growing children and requires reintervention. And I was also puzzled to learn about the Ross procedure at some point, but we also heard that today. But the idea is that you take the functional heart valve and place it in a different position, replace the other valve, was quite interesting to me. So the common goal must be for pediatric patients to get living heart valves in the end. So the different approaches, I'm not going into detail for this particular one, but the approach of in situ tissue engineering or the guided tissue regeneration, it relies on the natural regenerative potential of the body. And in the end, this should enable us with a simplified process prior to implantation. So what could be the path forward? I said the patients needing valve replacement is going to triple in the next 50 years. The current valves lack growth and remodeling, and they limit the long-term outcomes, especially in younger patients. So let's see where the future lies. I want to give you some insights from imaging, what imaging could bring to the tissue engineering world of heart valves. So from the management of valvular heart disease guidelines, we have different modalities we can choose from. On the left-hand side, there's Doppler interrogation. It requires meticulous attention to detail, and it really needs expertise to be reproducible, comparable. It's really observer dependent. In the center, there's imaging from cardiovascular MR, CT. It's not that observer dependent. And on the right-hand side, there's, I would summarize it as invasive technologies, catheterization, and also blood samples. So catheterization provides us with a pressure mapping, also a very important measure in heart valves. So I would like to focus on the magnetic resonance imaging part, because that's also my research field, and I want to show you what it's capable of. So this is animations from 40-flow MRI, and they really enable a compelling evaluation of velocity fields. I would like to give you a second to appreciate the level of detail on the left-hand side for a healthy volunteer, and on the right-hand side for a patient who has undergone aortic root replacement, valve-sparing aortic root replacement. And you can see the difference in the flow fields, and it's really a 3D representation over time, very detailed with very many options to evaluate. So 40-flow MRI is really stemming from the clinics, and there's also a plethora of clinical use cases. It's congenital heart disease, aortic aneurysm, aortic dissection, and so on. But most importantly for us, aortic or pulmonary valve stenosis. You can see on the right-hand side the possibility to evaluate, for example, streamlines, the magnitude image to segment the vessels, and then the overlay magnitude with in-plane velocities, for example. So there's really a wide range of options, and I want to show you some details of that. So there's a plethora of clinical parameters also that can be evaluated. All of that within a single measurement. So the first one would be, for example, jet angle. So this is really the angle between the systolic jet and the normal of the cross-section of the vessel. And it's an important parameter as if the jet impinges on the wall, the cell and the endothelial cells would realign on the aortic wall. The flow displacement is another one. And in-plane rotational flow is also possible to evaluate in 40-flow MRI, as it's a 3D velocity measurement over time. Wall shear stress, we have heard that today, as shear forces are considered the main factors of development and the progression of aortopathy. Its values, and especially its distribution, are directly correlated to the problem. And another parameter that I want to introduce today is turbulent kinetic energy, as it correlates with the irreversible pressure loss across a valve, for example. Viscous losses, they relate to the thermal energy and loss means losses in energy. So this is something that's suboptimal in the heart. And also the pressure gradient, I will introduce that today also, is a useful biomarker for any valve. And the pulse wave velocity is indicative of the vessel stiffness. I told you many good things. Let me start with a downside. It takes time. So on the left-hand side, I tried to illustrate taking a picture with any camera. It's mostly instantaneous, and if there's not too much motion, you get a sharp picture. On the right-hand side, I illustrated the MR measurement. So it's a very continuous process. If it's time resolved, we have to repeat our acquisition protocol fitting maybe in this one rectangle over many times. We're acquiring in Fourier space, so we have to fill up the Fourier space. And if we want to have certain parameters, we have to do this many, many times. This is why the measurement takes actually quite long, but in the end, and I think this was the very first picture I acquired during my PhD, using a standard sequence though, but it's very magnificent nevertheless, but it takes time. So for the flow MRI, if we don't use any acceleration at all, a scan would take 71 minutes, but luckily we're down to 2 minutes for only the big vessel scan and 5 minutes for a whole heart scan. On the other hand, there's data dimensions. We want to acquire as much information as we can gather during a specific time. And on the other side, there's resolution and accuracy. So this is the limitation that's really set, and it's not possible to get the best of all of the three. So what we nowadays have is 3D plus time. It's 4D flow MRI, and the spatial resolution is around 2 millimeters. And the temporal resolution, according to the guidelines, also is 30 milliseconds. But again, that acquisition may take 5 minutes, but the video you see or the data you get in the end is just one heartbeat. And why it's very important to have much information in the end is illustrated by this study, and that's actually the title of the paper, Two Wrongs Sometimes Do Make a Right. The authors compare Doppler imaging against 4D flow MRI, and it turns out that certain assumptions in Doppler imaging, namely the assumption of a circular shape of the left ventricular outflow tract and neglecting the boundary layer, sum up to 0% error, even though this is only valid if it's exactly like that. Whereas 4D flow MRI shows you the truth because it's not circular and the boundary layer cannot be neglected. So this is the information, the additional information that imaging brings to the equation. So I mentioned two parameters that I want to talk about today. It's pressure mapping and also turbulent kinetic energy. So let's start with the pressure drop across valves. Many of you have heard maybe the simplified Bernoulli equation. So that is used to estimate the pressure drop across a valve using the maximum velocity at a single point. It's regularly used with Doppler data, but there's certain assumptions. So the first assumption is the flow is steady and incompressible. And the second is that there is negligible proximal velocity. So it's only the maximum velocity that is taken into account. That's why wise authors introduced the modified Bernoulli equation, also taking the proximal velocity into account. And the picture on the right actually shows you a very interesting phenomenon. So depending on the geometry of the left ventricular outflow tract and the ascending aorta, the pressure difference could be different. So the modified Bernoulli equation, in this case, would overestimate the pressure drop, whereas in the ascending aorta, there's actually pressure recovery. For another patient, this may not be true anymore. So that's why there's also extended Bernoulli, which takes the geometrical parameters into account. So this was based on Doppler data. What can MRI bring to the equation again? Pressure drops can be estimated using MRI. This can be done by using the Navier-Stokes equations, specifically the pressure-Poisson equation. And again, there are certain assumptions. First of all, blood is considered incompressible. It's a Newtonian fluid, and there's no turbulence involved. If we do this, we can come up with this equation, which includes certain terms that relate to transient forces, convective forces, and viscous forces. And with this, and a nice segmentation in the image, it's possible to calculate the pressure drop by solving this equation. But I mentioned there's no turbulence involved, and if there's aortic valve stenosis, for example, there may be turbulence in the flow field. So if this is imaged, and it can be imaged by MRI, we improve the estimation of the pressure drop across the stenosis. So it's really kind of a bottom-up approach. Even though we start with complicated equations, we start with simple assumptions. And on the top, you see that including turbulence actually changes the pressure drop in the ascending aorta compared to when turbulence is neglected. And the top row is a simulation, and the bottom is actually an in vitro experiment. So I was mentioning turbulent flow and turbulent kinetic energy, but the question is, what is it? What is it really? On the left-hand side, I tried to plot a flow profile that could be found in laminar flow, or a Womersley profile that could be found in laminar pulsatile flow. And the important thing is that for laminar flow, there is a linear relationship between the pressure applied and the mass flow actually going through any vessel. But as soon as there is, let's say, a stenosis, there's jet formation and turbulence, this linear relation does not hold anymore. So you see this illustrated in this plot here. And one equation that tells us something about if there's turbulence or not is the Reynolds number. And rule of thumb is around 2000 could be turbulent already. And that's very likely to be in any aortic stenosis or maybe valve replacements. That could be a very important parameter. Turbulent kinetic energy is found where the jet breaks down. There's a lot of shear stresses involved also, and this can be imaged by MRI. I will show you in a second. So what are the clinical implications of turbulent kinetic energy? I mentioned it, and we also seen it today, that damage of red blood cells is related to turbulent shear stresses, which engineers would call Reynolds shear stresses, which may have an impact on prostatic valve design. And there are indications that turbulent flow also contributes to thrombus formation. And the plot on the bottom shows actually that using the mean pressure gradient that was measured invasively in patients against the turbulent kinetic energy allows us to differentiate very well between patients and healthy volunteers. And yeah, this is the same actually, it's just normalized TKE on this side. But it's again a distinction between those two groups. And very interesting, the mean pressure gradient did not allow to differentiate between tricuspid and bicuspid aortic valves, whereas the turbulent kinetic energy did allow us to. So in the end, you could get the feeling that there is a bit more information incorporated in actually measuring the turbulent kinetic energy. So how would it look like? This is in vitro data. It's a straight phantom, so it's an MRI in vitro experiment. And it looks a bit like a candle lighted, but this is what I mentioned before. So where the jet actually breaks down, this is where turbulence production and turbulent kinetic energy is high. Also another experiment from a group in Sweden. same behavior. And the results are very comparable with CFD simulations. So I'm pointing towards comparison of in vitro and in silico experiments, but I'm coming to that in a second. And for in vivo, we see that when we compare healthy volunteers against patients, that the turbulence level, the turbulence kinetic energy across a valve stenosis is quite elevated here. I don't want to dive into numbers here. I just want to give you an overview of this. So let's come to the combination of disciplines. We've seen that we can map pressures from MRI, relative pressures. We can map turbulent kinetic energy, and also, of course, velocities, three-dimensional over time. What can we do with it? And two projects I would like to highlight. One is, can we do MRI for tissue-engineered heart valves in bioreactors? And that's a project from HVTE Aachen in Germany. And the authors built a bioreactor that is meant to non-invasively monitor, and that's over a longitudinal study, the THV scaffold remodeling, extracellular matrix decomposition, and inflammation onset. So it's really meant to be a multi-imaging bioreactor, and they use a non-degradable PET scaffold and PLGA fibers labeled with spions, so superparamagnetic iron oxide nanoparticles. And I come to that in a second, why that is interesting for MRI. So on the left-hand side, you see the bioreactor. It's using a preclinical system, a small bore system with a mouse coil, and the bioreactor was designed to fit exactly in that coil, enabling very accurate imaging because the coil is quite close to the bioreactor. It's air-driven, so it's MRI compatible because it has to be metal-free. So they used in-house synthesized oleic acid-coated spion-labeled heart valve textile for manufacturing this heart valve. So it's very clearly explained in the papers, and the authors, I would like to thank them here for sharing these slides with me. This is from their paper, and as you see, the iron particles incorporated in the heart valve tissue enables us to do MR imaging so that they are visible in the MR image. If you wouldn't have incorporated iron particles, you wouldn't see the valve itself. But this is really interesting for any imaging approach in tissue engineering. And you can appreciate the opening and closing of the valve here, and also from this view, from the axial view. It's very clearly, it's very distinctive, very distinctive contrast and for the opening and closing here. And of course, on top of that, you could do all what I mentioned before, everything that I mentioned before. So flow imaging, actually characterizing the hemodynamics of the system, and this would lead to a very much more very, very distinctive description of the heart valve itself, maybe even over time. And this is unpublished data of the authors that they shared. They also managed to label, the heart valve tissue, but also the medium with commercially available tracers, and did magnetic particle imaging with the bioreactor. And this enabled them to not only reconstruct the heart valve textile, but also differentiate between the heart valve tissue and the flow medium here. And that's quite interesting to incorporate another dimension into the imaging process. Sorry. Another approach is concerned with twinning, and that's something that colleagues and collaborators from Charité are interested in. So for aortic valve stenosis, for TAVI interventions, It's very important to know your sizing and somewhat predict the pressure drop in the patient before and after intervention. Also for mitral valve regurgitation, it would be interesting, for example, for the mitral clip, where to clip the mitral valve to get a certain result. So in intervention planning. And this is done actually in finite element analysis and CFD simulations here. And this enables us to somewhat predict the flow field after certain treatment. And from that, you can draw your conclusions on how to treat a patient in the future, hopefully. I'm going to go over this. So again, it's really meant to be a pre and post comparison. That's a left ventricle heart model. But the question is always, when we do simulations, how valid are they? How close are they to reality? And that's why verification and validation is really a major challenge in any in silico model. And they thought about using 4D flow MRI as a gold standard, as they want to replicate the in silico model in vitro and measure it in the MR. And the anatomy of the patient was segmented from CT scans, also the valve movement. And they had data from MRI, CT, and Doppler from the same patient, which gave them a rich data set to be applied in vitro. And there's two different approaches for doing the simulation. One is actually moving the wall, which takes a few weeks, I think, on the cluster to compute. Moving the wall, which basically pushes, moving the wall, or applying the wall movement as a velocity to the velocity field. And that takes several hours on a personal computer. So it's also there, the level of detail can be scaled according to your needs. And this was the project I could participate in. So we built an MRI-compatible flow loop, which is a left heart model. And it's an elastic PVE left ventricle model, including mitral and aortic valves. And you may see that it's not a perfect valve, but nevertheless, we see that it somewhat resembles already patient specifics from the flow field. So these valves were 3D printed and reproduced for using it in this compatible flow loop. And again, everything has to be MRI compatible, so there's no metal involved. But the 4D flow field enables us to, first of all, compare to the in silico model, and second, to reiterate in any valve design, in any flow loop design. So with this, I already come to the closing of my talk. The main idea I wanted to transmit to you today is that there is benefit in bringing disciplines together, especially in bringing MRI in vitro and in vivo also together, and in silico. And so the main idea is that it doesn't have to be a linear process. So we don't have to produce a scaffold, do a bioreactor test, monitor flow conditions, and then end up in the patient. But it could be a circular process. So the first loop could be here already. If we take the results from the in vitro measurement and feed it back to, let's say, a twinning or a prediction model to optimize the scaffold, polymer, whatever you need. But then MRI, again, is like very beneficial in terms of imaging, because you can also do this in vivo. And if we don't stick to a preclinical system, but to a clinical human system, this feedback loop can also be incorporated. So this would enable, especially for tissue engineering, longitudinal studies of valve growth and especially characterizing the flow fields in terms of valve optimization in the future. Okay, with this I would like to thank everybody who is collaborating with me, also the European Union for financing me via our Marie Skłodowska-Curie Fellowship, and colleagues who shared some slides with me for this presentation. Thank you very much.
Thank you. I already see some questions from the audience.
Yeah, very nice talk. So you briefly, when you mentioned some of the resolution, you said 2.5 millimeter. I was just curious, like how that impacts ability to measure wall shear, especially when you're talking about leaflets tend to be so thin, and just your comments on it.
Okay, tough question, I would say. I would say it actually impacts it. So there are works on evaluating the impact of resolution on wall shear stresses. The simple answer is we don't get any lower than that for a clinical scan. It's 2 millimeters isotropic. But again, if we do in vitro experiments, we're not limited by measurement times. So this would be an opportunity to go down with resolution and extrapolate the results to in vitro results as well. Thank you.
Yep, and then we have one more question here in the front. Yep.
Oops.
So, Dr. Delicate, thank you for your overview. So if you were to compare all the tissue engineered valves that we can make in this room, not that many, but and you would follow them with MRI, can you give us the key marker that you could image for us? And I'm not talking about regurgitation or whatever, to predict the success that we could also use, for instance, in repetitive ultrasound or echo images? Mm-hmm. Or is this the future?
So I would say hemodynamics are the most interesting part, flow fields, because we can have really distinct information from that. Cardiologists are mostly interested in the pressure drop, but we can directly measure that. So for a longitudinal study, if this was your question, I guess.
Yeah, so we are working with living tissues that will change with time, so still hemodynamics, right?
I would say so, yeah.
Okay, good, thank you.
Okay, thank you so much. Let's thank our speaker.
Thank you.
Okay, and then we'll be moving on to our next speaker, Dr. Yaseman Zamani. Not here. Okay, we'll be moving on to our next speaker. Okay, which is that a K? Dr. Malikosini? Yep, okay. Thank you so much. And then...
Unfortunately, my colleague is not here,
okay.
So I will present for her.
Great, and then this will be on the topic of can losartan controlled release improve the biohybrid cardiac patch and preventing left ventricular pathological remodeling?
Yes. Presentation mode. Okay. Good morning again. No, I don't need it. Unfortunately, my colleague could be here, so I will present her work. Of course, if you have any questions, please, you are kindly invited to write her. There will be her email. So her work is about can losartan controlled release improve the biohybrid cardiac patch in preventing left ventricle pathological remodeling? As you know, the cardiovascular disease are the leading cases of death worldwide. Among these, the heart attack myocardial infarction are particularly impactful. So the myocardial infarction occurs when one or more sections of the heart do not receive sufficient oxygen-rich blood. So following the myocardial infarction, the heart undergoes pathological remodeling to maintain normal cardiac output. So these pathological remodeling, such as heart dilatation and elongation, finally lead to scar formation. In previous study of Professor Antonio D'Amore, he showed that applying a biohybrid cardiac patch can reduce the maladaptive remodeling and improve the cardiac function by providing the mechanical support to the left ventricle, facilitating the self-infiltration and inducing ontogenesis and resulting in improving the cardiac function. Okay. So this project aims to improve this cardiac patch by incorporating drug-loaded microparticles and have a controlled drug release. The drug is losartan potassium, which can facilitate the scar healing and reduce the maladaptive remodeling. So, as I mentioned, this project aims to fabricate a bilayer biohybrid cardiac patch made by polymer and ECM, and to improve the functionality of this patch, there will be an incorporation of microparticle drug loaded into it. The experimental procedure includes 4 phases. First of all, we synthesize in polymer the PECUU. Then there is the desolarization of the wall porcine heart to obtain the DECM powder. And the third phase is the fabrication of the drug-loaded microparticles. And then there is the electrospinning of these 2 materials, the polymer and the ECM gel, through a double electrospinning technique. Here in the bottom you can see the bilayer, and we can distinguish the 2 sides. One of the extracellular matrix rich layer where there are the microparticles, and the other the polymer that is the PECU, as I said. To be sure that after the desolarization, all the cells were removed, my colleagues performed some histological analysis. In particular, she used the hematoxylin and eosin staining technique, and you can see that all the cells were removed from the tissue. And also the Masson trichrome staining confirms that the collagen fibers are preserved and that the desolarization process didn't compromise the extracellular matrix structure. Moreover, to be sure, she also included a DNA content analysis, and as you can see, the samples desolarized present lower DNA content. It's under the threshold of 50 milligram DNA on milligram ECM. In this slide, as you can see, there is the fabrication of the drug-loaded microparticles using the double emulsion technique. The microparticles obtained were well formed with an average size of 20 micrometers. To have also a mechanical characterization, my colleagues present some mechanical tests comparing the bilayer with the microparticles. First of all, she performed some uniaxial testing, and as you can see, the results showed highest differences in the circumferential direction compared with the longitudinal direction that she distinguished in the cardiac patch. Also for the bilayer with the microparticles and that without microparticles. And this highlights the anisotropic structure of the tissue. Then she performed some suture retention tests that indicates the maximum force that the samples can withstand without breaking at the suture point. After this, she performed some biaxial testing that confirms the anisotropic behavior of the tissue with the circumferential direction stiffer than the longitudinal direction. However, there is no significant differences between the bilayer without microparticles and that with the particles. To conclude this mechanical analysis, she also wanted to compare the anisotropy ratio between different groups, in particular with the human, the porcine ovine, and the hair patch. And as you can see, there is no significant differences between the samples. In these slides, she wants to underline the anisotropic structure of the cardiac patch in the ECM side and also in the polymeric sides, and comparing always the bilayer with and without microparticles. The results demonstrate the anisotropic nature of the patch, as the reintersection index is greater than 0.5 in all cases. In these slides, as you can see, she wants to see also if the bilayer have integrity in their structure, and the two layer doesn't show us any signs of delamination. So it's a good results for the bilayer cardiac patch. After this, she also focused on a 2-week drug release period, as the patch is highly biodegradable over 50% in its structure within 2 weeks. The drug release test demonstrates a controlled release over the 2 weeks period, and additionally, contact angle measurements confirm that the patch is highly hydrophilic, which is a critical factor of promoting the cell infiltration. This is just an overview of the drug release calculation that she performed to obtain the previous results. And the cells were cultured on both the ECM side and the polymer side of the patch, and a cell viability test, the Alamar Blue assay, was performed. The results shows that the patch is not toxic and supports the cell growth. And histological analysis also confirms a successful cell infiltration into the patch. To conclude, in these slides, you can see that a manually counted number of cells in both sides was performed for the polymer side and ECM side, and there is no significant differences in cell number between the two sides, with a higher cell density observed in the ECM side. This is attributed, of course, of the bioactive nature of the extracellular matrix, which promotes better cell attachment and proliferation. So thank you. This is the email of my colleague. So if you have any questions or curiosity or suggestion, you can write to her. Thank you so much.
Thank you so much for stepping in. Okay. So yes, please do follow up the email for questions for that previous talk, and then we will introduce our last speaker, which is John Toftegard. Oh, presented by Jonathan Butcher. Hello. Okay. And then the title of this talk is Incremental Stretch Increases Strength and Toughness While Increasing Graft Size in 3D Printed Engineered Heart Valve Leaflets.
Okay, let's make sure I understand the point. There we go. Okay. All right. Thank you very much. I'm sorry that I have to present in my colleague's stead. I'm very interested in my students arriving back into the country, so I am presenting on his behalf, and I'm happy to share the work that we've been doing recently in trying to improve fabrication strategies for complexity within engineered living heart valves. And so, as we're all very aware, the heart valve is not only anatomically complex, but it has very complex microstructure. It has tissue anisotropy. It has significant nonlinearity, and these components interact with each other during the dynamism of the aortic valve, as well as over the lifespan of the valve in terms of continuously remodeling with respect to the mechanical forces in which this tissue has to maintain. One significant example of the need to grow as well as strengthen is in pediatric populations. And as we have been learning about, many pediatric patients suffer from various valve diseases, and an innovation that has been studied for decades is the Ross procedure for developing a pulmonary autograft into the arterial circulation. And so in the adult, this graft works very well, and as we are aware, there are challenges still in the pediatric population to maintain a graft that grows rather than dilates, and strategies to both monitor those but also to engineer those performances are still going on. And so this is an important area for engineers to participate with clinicians. And there's been a lot of work trying to fabricate a living valve strategy, not only as a pulmonary replacement that could be living alongside that arterial graft, but also as a conduit itself to eliminate the potential double valve risk in the pulmonary autograft. And so we've learned a lot about these different fabrication strategies. They have significant improvements over 2 decades that have been studied. There's lots of different fabrication strategies. Among the enduring challenges has been the need to demonstrate growth, as well as the consequence of leaflet contraction that tends to happen in some of these designs. As we've learned this morning, some very exciting results of 18 months of function in a growing lamb is very exciting in this tri-tube conduit designed by Zishan's company. One of the things that is required for that valve is 50 days plus of in vitro culture, and this is another significant risk in the development of a valve in terms of potential for contamination, and also the desire to control the development of the graft in this long-term in vitro condition. Any strategy that we could do to accelerate that development and control that development would be excellent. And so one of the studies done by Zishan, this is now like 15 years ago, plus pursued the idea of changing the magnitude of a cyclic stretch profile to be able to encourage continued maturation of a tissue construct. In this case, it's a strip of tissue that you are cyclically stretching. And so the idea behind this is basically the fetal and pediatric course. Your heart increases its hemodynamic propensity, subjecting that valve to increasing mechanical force. So the idea is if you can increase the mechanical load, then maybe you can exercise the tissue to become stronger. In this particular example, though, the cyclic stretch always goes back to the same initial dimension. And so one of the thoughts that we had was maybe there's a way to take advantage of this same concept, but also be able to assess the propensity for growing at the same time. And so we are looking at this cyclic stretch in a kind of a mean sense and thinking about combining a mechanical load with a physical extension of the tissue to see if both of those can work together to grow and mature the tissue. And so to get a kind of baseline, we developed a micro-fabricated post system similar to multiple groups, but this is now something that we can do in a high-throughput system where we can now assess the relationship between the time-dependent culture of the tissue with various protocols that we can give to this structure. And so what we find in these tissues is that after 14 days, we pretty much plateau in the ability of a statically cultured but yet mechanically stressed tissue to achieve its kind of final mechanical stress. And this stress is, not the strength we would like, but it is still, significant. And so thinking about how to utilize the mechanical conditioning before, we developed a strategy to incrementally stretch this tissue. So we basically have a system where we can progressively lengthen this tissue while maintaining mechanical load on the tissue. And so we're calling that incremental static stretch. And so in this concept, you're accommodating the remodeling of the tissue simultaneously with its growth of the tissue, and then seeing how that affects the structure of the tissue that we generate, as well as its mechanical properties. So to assess potential stimulation regimens that incorporate this stretch as well as the timing of the changes in stretch, we developed several different protocols. And so here you can see whether we just have a static control that's the same way we did before, again going to 14 days because that was the maximum that the static did, and then various protocols to stretch to different final lengths as well as different days in which we would modulate that stretch. Now, these are kind of exploratory in the engineering side, but one could make arguments about the time dimension as well as like the native progression, although this wasn't exactly what we were testing. We were just testing whether you can do early versus late transitions. So this is accommodating a bunch of different options so that engineers can do things that the human body doesn't naturally do to try to understand these relationships. And so what we found, fortunately for us, is that when you apply this incremental static stretch, we can achieve an almost fourfold increase in the mechanical strengthening of this tissue, simultaneously with increasing its size to over 100%. And so while you are stretching this tissue, it is mechanically strengthening to become essentially stronger, and it still retains its ability to stretch as a soft tissue. So this was exciting to us, and we found that an earlier transition, if you can see in the bottom right here, to the stiffening increased that remodeling. So if we kind of stretch it earlier and then slow down how much we stretch later, it seems to have a beneficial effect. And so then looking at the remodeling phenotype with this stretch, what we find is that the so-called remodeling interstitial cell, which has a kind of an elevation of both fibroblastic and smooth muscle-like protein expression, correlated with this incremental stretch that was optimal. Well, it just was optimal in our hands in terms of generating the earlier transition and stretch. And so there was actually a correlation between the presence of this remodeling phenotype and the resulting strengthening that we found in the tissue. And so we extended that further and said, let's manufacture some leaflets. And so we developed a hemispherical leaflet model that we subjected to these same kinds of protocols here, again achieving over 100-fold growth in terms of the area of this tissue. And in the same vein, we found that by progressively, incrementally stretching the tissue here in these different time points, mimicking what we found in kind of the unidirectional stretch, we were able to increase the strengthening of this tissue simultaneous with maintaining this remodeling interstitial cell phenotype. And so then we tried to do a step further where we said, well, let's take this tissue and now we will biofabricate fibers. And so instead of just having a homogeneous tissue structure, now we put collagen fibers that we can now tune the anisotropy, the density of these fibers inside this tissue, and then culture these constructs with these additional layers of complexity. what we find, interestingly, is that these fiber bundles tend to orient the cells proximal to those fiber bundles and contribute to developing a locally anisotropic extracellular matrix. So the cells reorient, and that is associated in our hands with biomechanical strengthening while retaining this anisotropy. So we can fabricate the tissues with stiffer, stronger matrix with more fibers in certain directions, and then when you have a different ratio of fibers in those directions, you can appreciate the anisotropy that we continue to generate, which is greater than a lower density of fibers versus a higher density of fibers that are in isotropic directions. And so this opportunity allows us to study both fiber densities as well as the advantage of this incremental stretch. And so we combine both of those in this particular example where we are stretching the tissue to get to a 50% increase in size. What we find is that while we stretch the tissue in its fiber configuration, that we get a significant strengthening over just patterning alone or stretching alone. Although what we're still studying here is the ability to maintain the anisotropy in the fiber dimensions. And so we think what's happening is the presence of these fibers are inducing an additional axis of remodeling that seems to be counteracting or collaborating, I should say, with the fibers to potentially make different matrix inside those individual fiber domains. And so we find, again, that the strengthening tissue has this more remodeling interstitial cell phenotype. So overall, the opportunity to encourage a defined growth endpoint for, say, with tissue engineering technologies may allow for tissues that are not only better able to function at the length that you want, but we are also learning about how to stage-wise coax the growth of a graft so that you can potentially exercise that graft to be capable for expanding in the conditions that you want. And so in the environment like this, we have a better throughput to be able to study this on the bench. And so the combination of these technologies together, we think will be excellent for being able to engineer more physiologically complex engineered leaflets. So with that, I'd like to thank again you for your time, but also to acknowledge John, who's done a lot of work in our group towards this presentation. I'm happy to answer any questions.
Are there any questions from the audience? If not, then I can start with a question. Okay. I was wondering, because you have this really nice graph where you stretch to the same point, but then at the earlier time point, you see a significant increase in LVSMA compared to the other groups. Do you also in the tissue see any breakage points where there's then more remodeling because it's maybe stretched too fast? Or
that's a great point. We found, I can maybe go back. There was you see at the end it sort of tails back off again. So we did find, at least with the conditions that we started with, we found that an earlier stretch, and then you see how it's held for, from day 7 to day 14, ended up being stronger than one that you stretch progressively the whole time. So that's something we're still looking into a bit. It does suggest that the earlier stages extending seem to be beneficial. I totally understand your comment about, well, what if we stretch to 200%, right? At some point, it's just going to shatter. And we were expecting the stiffness to drop way, or the strength to drop way down. So it might be a consequence of staying at the 14-day time point, which was sort of the static maximum. These are all the dimensions of questions we're trying to answer now that the system is kind of up for a high throughput test, but these are great questions.
I also had a question. So considering this kind of going off of that, how much strengthening is too much strengthening, as the eventual goal is to implant this and then have infiltration of circulating cells, have you done any work to show exactly, other than the mechanical testing you've done, the changes to the ECM and if that is kind of suitable for cell infiltration going forward?
Yeah, that's a great question. So in this context, we have done an analysis of collagen matrix turnover, as well as the maturation of that matrix, like polarized light. We do find that the strengthening correlates pretty exactly to the development of the sort of the higher mature polarizing collagen fiber, patterning. What we are interested in understanding better is how the cells are remodeling inside those mesodomains in between the different fiber contributions. Like, because, when you have a high density versus low density of fiber bundles, perhaps that is a feature. We also have, I didn't have the ability to present it today, but differences in the bundle density, meaning the actual material density of the bundle itself compared to the bulk density, so thinking about the differences in mechanical properties there.
Sure.
So hopefully we'll have, maybe I'll talk about that in September. We'll see.
Yeah. I mean, it does lend itself nicely because you're doing this biomaterial development in-house to kind of utilize either some tagging techniques or like maybe different species to start looking at how the fibers that you were putting down are changing as a function of what is being deposited endogenously from the cells. Do you have any idea of how that is changing?
Yeah, that's a good question. So we have been doing collagen bundles inside of fibrin for that kind of reason. But we're not smart enough to like tag the human protein versus the porcine protein or whatever.
Let's
so
talk.
we may
can
have
do
to.
it.
Yeah, exactly.
Okay, great. Okay, there's another question here in the front. Oh, maybe this will be our last question.
Oh.
Yep.
Easy question.
Regarding to your college fiber bundles is increased or whatever change, and you can add other ECM component associated fiber be increased or changed?
That's an excellent question. I mean, when I think of the remodeling of the extracellular matrix, of proteoglycans would be a big component that I would be interested in. We have not actually done the profiling of all the different proteins. We were starting with like macro categories. We did not see, like on a macro scale, the significant change in glycosaminoglycans, which was somewhat surprising. But then again, like individual proteoglycan components can be very important. So this is, again, something we hope to continue to understand with the next set of experiments.
Another thing, question regarding to you said incremental stress. How those kind of stress mimic in vivo?
Yeah, this was, I was trying to head that off at the beginning, but you might as well address it directly. So this is not the actual in vivo stress, right? In the sense that in vivo, you have a growing, pulsating, conduit with the leaflets that are flapping around, and so you have a very complicated hemodynamic environment. So I was thinking about reducing the order of possible mechanical loading so that we can learn something about maybe the first level of the mechanical conditioning environment. So in this case, these tissues are under mechanical stress by virtue of being on these posts, but then we're also extending the posts. And so like one would increase the cyclic stretch, perhaps to a different magnitude, in our case, the baseline is also moving. So we have a baseline strain state, and our hypothesis is that tissues adapt very quickly to that baseline state. So if we could approximate the cyclic load as a mean, right? So you have an amplitude that goes from some max to zero, and so if you think of the mean as a constant, and we sort of reduce that load, or that order, and then add the complexity of the increasing baseline, That allowed us to test both of those interactions in this particular experiment. I think it would be great to do this in the full complexity of, you know, a growing valve and a growing mechanical environment. But as we've learned today, that's a very complicated system. And even if you were successful, it might take many days to learn how these interact and being able to extract what caused what when you're changing all of those variables. So this was our attempt to try to learn features that then we can hopefully input to perhaps reduce all of the experimental space. You know, should I test the high pressure, low pressure, how many different, you know, transitions? And so we're hoping to basically reduce a lot of that to enable, you know, other people who have these conduits, they might be conditioning in vitro, or, you know, testing in different animals to say, this progression might be the best.
Thank you.
Yes, thank you so much.
Okay.
So with that, we close our last session, but we also close the meeting for today. So there will be a reception outside after this where you can continue discussing the amazing topics that we discussed today. I want to thank all the speakers for their really nice presentations, also all the moderators that helped during the day, and the technical team sitting there in the back. Also really thank you very much for making it all run smoothly. And I want to thank HVS 2025 for hosting us again. So see you all out there.